All right, so who is not back?
I'm back, sir.
Hi. All right, so let's do a roll call. Brittany? Brittany?
She's probably eating again.
Dang.
Christina?
That was tough.
Christina?
Here.
Kathleen Dulligan?
Here.
Cassie Enriquez?
Here.
Jordan?
Here.
Tejindra?
He's trying to log in, Professor.
Jenna?
Here.
Leslie?
Here.
Kyra? Tina? Sakira? Tina Matthew?
Here.
Okay. Sonia McClare?
Present.
Okay, I see Brittany's back.
I'm here, sorry.
Farah Mercy?
Here.
Angela Nelson? Angela Nelson? Hello, Angela? Mariah?
Here.
Ariel Palmer?
Here.
Yvonne? Becky? We lost Becky. Jen Perk is here.
I am here.
Elijah, Paula Amayo, and Kanisha Tom,
I'm here.
and Roselle.
I'm here. I'm here.
All right, so we're missing Indra and Kevon. And
Professor, when I tried to log back in, it said that you had another meeting open, so I had to like leave and come back. So maybe they're just having issues.
oh, I already ended that meeting.
Oh, okay.
I don't know why that came up. Anyway, I'll just check back later. Where is my... All right, can you see this?
Yes.
Okay, so where did we stop? I was blabbering about oxygen, right?
Yes.
Yes.
All right, so to recap, yes, it is true that we do not give too much oxygen to any COPD patient. However, if they need it, then we have to give. At what, how much do we give?
2 to 4.
2 liters.
Well, we just read this paragraph, right? So again, if they're, let's say their oxygen saturation is at 86 and you're already giving them 2 liters or 4 liters and their oxygen level is at 86, what do you do? Do we tell
the doctor?
Between
Go
80 and
higher.
Do we tell the patient? What if the doctor doesn't answer?
You don't raise it higher because a COPD patient can't have any more than that.
Okay, so you picture this. Okay, so Jenna has COPD. You're gasping for air. You're staring at me, pleading, please help me. And then the nurse comes and tells Jenna, I'm sorry, I can't give you more than 2 liters, okay? You have COPD. I'm so sorry. Okay, imagine that scenario. What
Well, you're
will
not going
happen
to
to
say
the
that.
patient?
We will
Level
increase.
up in 88 and 92. Isn't that, if that's the guidelines, aren't we supposed to follow those guidelines? Even if their oxygen level is at 4 liters per minute, if they're still not within those parameters, aren't we supposed to make sure that the patient at least hits those parameters?
So that was my question. So what will you do? The patient's at 4 liters already, and then their oxygen saturation is still at 86%.
We'll give the
Notify the
ventilator
healthcare provider.
Increase by
20%.
one.
Give the patient oxygen. All right. So he says here, patients should receive, even those with COPD, should receive oxygen therapy at rates appropriate in order to reduce hypoxia and reach at least 88%.
Professor?
So we would increase it by 1 until they get that to that maximum level. It will go up as they continue. So if we increased it to 5 and they're still not at 80, at 88, in between 88 and 92, we can increase it by 6 until they reach their maximum level.
Yes, however is needed until you reach that goal. Is that clear?
Professor, how long are you supposed to titrate for? And especially the patient with COPD, because what?
That was my next. If
What?
no longer needs it, do you continue at high oxygen rates?
No.
No. So if you can titrate up, can you titrate down?
Yes.
Any other question?
That didn't really answer it, but okay.
No, go ahead, Jenna. What was your question?
No, nothing. It's okay. We can continue.
Jenna, if you get them to the 88% to 92% O2 level and they're constant at that, you titrate down and see if they're stabilized, and you continue to titrate until.
Yeah,
So there's no set time. It's just watching your patient.
that's correct. Just like any other medication, oxygen is considered a medication, correct? So if they no longer need it, then don't leave them at that high of a rate, because you do know that they will have respiratory depression as a result, because you will suppress the drive to breathe. That is theoretically, again, I'd like to emphasize that's theoretically correct. So if you can titrate up, you should always also titrate down. Right? So if the scenario has already subsided, meaning the patient's condition has improved, then don't leave them at high oxygen rates. So this is what I mean by if you titrate up, you can also titrate down if they no longer need it. All right? Any other question? Violent reaction. All right, take that as a... All right, drug therapy. So they just summarized the drug therapy here. I will go to asthma, and then we'll go back to 578 later. I hope I can remember that page. Let's begin with the peak flow meter right here. So what is, for my asthma students here, what is a peak flow? Who uses the peak flow here? Anyone familiar with the peak flow?
Yeah.
All right, go ahead if you don't mind sharing. What is the peak flow meter? Is Sonia?
Well, they normally give it to me to check the capacity of my lungs.
Okay, was it given to you during an asthma attack or during?
Yeah, I was in the hospital after I had the asthma attack, and I had to be admitted. They gave me a peak flow.
Meaning you didn't receive it before the attack?
Not in the ER. I didn't. I got it when I hit the floor.
Oh, okay. So after the acute episode, right?
Yeah.
Okay, all right. Because just like the spirometer earlier, the same concept. we can't accurately measure your lung capacity while you're sick, right? While you're having an exacerbation. So a peak flow meter is given for asthma patients as well as COPD patients. So this is a handy tool. This is disposable. You wash it, of course, because you put your mouth into this mouthpiece right here, and then you blow into this. So there is a instruction here, chart 30-4 on how to use it. First is you set the peak flow meter at 0, which is right here. So you put that down all the way to 0, and then just follow the instructions. Either standing or sitting is also acceptable, but standing is best. Take a deep breath as you can, and then put the mouthpiece in your mouth, and then blow as hard and as fast as you can. You repeat this 3 times. Okay, of course, you rest between blows, and then you record the highest reading. That is your peak flow. Now, what's the significance of the peak flow? Now, there will be times wherein you have to distinguish between an asthma cough versus a upper respiratory infection cough, because you can get either one. Now, you'll be instructed to grab the peak flow if you're having symptoms, and then since let's say your peak flow is 400, if you're having symptoms like a cough usually, and then you grab your peak flow and then blow as hard and as fast as you can, do it 3 times. If you're meeting your peak flow or even exceeding your peak flow, are you having an asthma or a COPD exacerbation?
No.
Probably not. Most probably not, because your peak flow is good. That means the cough you're having must be something else, not an asthma attack. Is that clear? So is this a handy tool?
Yeah.
Yes. So either way, whatever your peak flow is, you call the physician and then they will ask you, so what is your peak flow telling you? So you tell the physician what your peak flow is, and then they'll decide on what to do, whether it's time for you to come into the ER, or if we can just adjust your medications, or if you need some other medication for the upper respiratory infection. All right. Questions? All right, so let's go to the medication now. So we have chart 30-6. Although again, this is labeled asthma prevention, but if you go under page 578, you'll see the same drugs are listed there. So here are your most common COPD exacerbation. Again, these are also used for asthma. First up are bronchodilators. We have 2. We have the rescue medications, which is your SABAs, or short-acting beta-2 agonist. I understand you already finished this with PHARM, correct?
Yeah.
Yes. So your SABA, most common is the albuterol. We have several brands here. Another is levalbuterol. This is another drug chart. So which part is testable?
All of it.
No,
Nursing application.
okay, it's always about your nursing responsibilities. What do you do? What you teach the patient. All right. Since this is a bronchodilator, and the patient most likely will be on both bronchodilators and steroids at the same time. And what have you learned so far? Which one do you take first?
Bronchodilator.
The dilator, and then followed by the steroid.
The steroid.
All right. So please read on your own your nursing responsibilities. Take note, I will also play a video on how to use the MDI or DPI, because that's one of your interventions here, or your nursing responsibilities is to teach the patient on how to use it. You wouldn't believe how many of these patients, even if they've been having COPD for years, that they don't really know how to use the MDI or the DPI, and which is the reason for unnecessary preventable hospital readmissions. If they just use them correctly, then they wouldn't be in the ER.
I'm
the
sorry, what page is this on?
568.
Thank you.
right. We have LABAs, we have salmeterol, and we also have steroids, which will follow. These are long-acting bronchodilators. So as stated here, do not reach for these during an asthma attack. It will not save you. The patient will die if you reach for this because this will have no effect whatsoever. Okay, they have a very slow onset. These have to be taken regularly. Whether you're having symptoms or not, these are taken regularly as opposed to SABAs, which must be brought anywhere you go because they need it in emergencies. These are short acting, they are fast acting. Okay, so they will relieve the symptoms right away. Are your rescue medications. Not so with LABAs. LABAs will not do anything if the patient's having an attack. Is that clear?
Yes.
Okay. Then we have others, which are anticholinergics. We have apotropium. Spiriva is a inhaled dry powder. And here are the steroids. I mean, they all end in zone, right? Fluticasone, or this is fluticasone is Ellipta. Then we have for patients with really severe exacerbations, they will be put on oral prednisone. Of course, this will be for about 10 days or longer, and you already know by now that these are always tapered, right? That we never stop them abruptly for whatever reason. Okay, so they should be always tapered. So I'll just test the most common, which are your both SABAs, all these LABAs, the ipratropium and tiotropium, then your steroids, and this last one right here, Singulair or Montelukast. These are specifically for leukotriene receptor. So these are specific cytokines that are responsible for the inflammatory responses, because again, COPD is a chronic condition, right? And in asthma, this is the cytokine responsible for the symptoms, the bronchial constriction and the inflammation. So if you suppress that, then that will improve the patient's symptoms. Again, this is only for prevention. Okay, so these are taken daily, right? It's usually 10 milligrams for adults and then 5 milligrams for kids. And I mentioned how to use it, which is the next one here, right here. Chart 30-7. And in order to illustrate this, we can read it, but I'll show you a video on YouTube that will see my screen or no?
Yes.
The YouTube one?
Yes.
Okay. All right, so if you see this chick right here, this is the correct one. This will correspond with the
Remove
chart.
the cap from the inhaler. Shake the inhaler well for 5 seconds. Hold the inhaler firmly by placing your index finger on top of the canister and thumb on the bottom of the mouthpiece. Sit up straight or stand up. Tilt your head back slightly.
By the way, later, the chart will tell you to instruct the patient to wash this. So this part is separate from the canister. So you remove the medication off of the mouthpiece of this. This just goes upside down here, and it fits into a circle. And this thing, of course, has a propellant. Okay, so because you put this in your mouth, then you'll have to wash this, well, preferably every day, because you do have saliva on it, and that will dry up and cause infections.
Exhale away from the inhaler. Put the inhaler in your mouth. Press the inhaler and start breathing in at the same time. Take a slow and deep breath.
Yeah.
Hold your breath for 10 seconds. Exhale slowly
Over
through
here
your
has a spacer. Sa kanya wala. I don't know. I know.
Repeat 2 to 8 steps after 30 seconds if another dose is required. If you are using a corticosteroid medication, rinse your mouth after all doses are complete.
And the preferred technique is the one using a spacer, which is, I recommend this video right here.
Remove the cap from the inhaler. Remove the cap from the spacer. Shake the inhaler well for 5 seconds. Insert the inhaler into the open end of the chamber. Ensure that the inhaler fits properly. Sit up straight or stand up. Tilt your head back slightly. Before starting to inhale, breathe out completely away from the spacer. Place the mouthpiece between your teeth and seal your lips tightly around it. Press the inhaler once, and then breathe in steadily and deeply. Hold your breath for 10 seconds, or as long as you are comfortable, and breathe out slowly. Repeat steps 3 to 10 after 30 seconds, if another dose is required.
All right, so that will demonstrate chart 30-7 as well as chart 30, no, only chart 30-7. because they put the one without a spacer and with a spacer here. Take note that if you use no spacer, you can actually hold the mouthpiece an inch or 2 inches away from your mouth. All right. So meaning it doesn't have to be in your mouth. This is handy if, let's say, you have to borrow somebody else's inhaler, because it happens. You don't have yours. You borrow someone else's. So that would be maintaining infection control at least. This 1 minute between puffs is if it's the same inhaler, meaning you're ordered to receive 2 puffs of the same medication. If it's 2 different medications, then it has to be 5 minutes between puffs. So the spacer is the preferred technique because if the patient is, let's say, very young or very old, don't have the dexterity or the correct timing about when to press the canister and when to inhale. So at least with the spacer, the medication circulates inside the spacer right here. So it circulates here. So buying them more time, allowing them to get more of the medication at their own pace. Okay, that way they're not hurried about when to inhale. Then they can actually get more of the medication. For a question before I go to DPIs?
No.
So the dry powder inhaler, unlike DPI, wherein you press the canister and then it sprays the medication, correct? A DPI doesn't have that. It doesn't spray the powder. So here, the container, they have different containers for this one by which it is dispensed, but they have the same, or I should say similar mechanisms of loading the dose and then inhaling it. So I have a right here.
Check the dose counter to see the number of doses remaining. Hold the inhaler properly in both the hands. Open the inhaler by using the thumb grip slide. You'll hear a click. Hold the inhaler horizontally. For loading the dose, slide the lever from left to right. You'll hear a click. Exhale away from the inhaler. Place the mouthpiece in your mouth. Take a quick and deep breath. Hold your breath for 10 seconds. Exhale slowly through your mouth or nose. If you are using Flovent Discus and have been prescribed to take another dose, then repeat this.
All right, hope you remember those suggested videos. By the way, for all these charts, as well as the peak flow meter, now I didn't read the entire chart to you, okay? There are details there that I use on the examination, especially the part where you know whether or not you're using it correctly. Please take note of those details, okay, for on the examination. These are one of the few things that are specifically mentioned on the NCLEX test plan. If you go to the PDF file, if you save the NCLEX test plan, these are one of those details that are mentioned specifically on the test plan, meaning these will definitely be on your NCLEX. And of course, I will likewise test it on the exam. Okay, so there are details here about what to do and especially what not to do, like this one, for instance. Remember again, the discus which contains the powdered inhaler, is powder. So that's why if you exhale, of course, that will put moisture into the inhaler, that will cause it to clump, and then therefore you could choke on it when you. I mean, even if it, you know, if it's even possible to suck it in now because it's now clumped inside the dispenser, or if it comes out, then like I said, it's already in a clump, so you may choke on it. Unlike the MDI where you wash it, this one is powder, so no washing. You can wipe the mouthpiece with just any wet wipe, for instance, just to keep it clean, but you can't run it under water. Questions?
No.
All right.
Actually, I have one. Can this be used as a rapid acting
No,
inhaler?
no such thing. Only the SABAs only come in MDIs.
Okay, so this is just like a maintenance thing every day?
Yeah, these dry powder inhalers are always maintenance. I mean,
Okay.
imagine if you're having an attack and then you're having to, you're asked to suck it in. I mean, you don't have that strength anymore to suck anything in. You can hardly get any air in. So that's probably the reason why they don't make DPIs. I mean, they don't make rescue drugs in a DPI form. Does that make sense?
Yeah.
All right, and then please read the details here. So LABAs are never prescribed alone. So these are again maintenance, but the patient should have a SABA, okay, for sudden attacks, for sudden symptoms. All right, so let's go to 578, and we have 5 minutes left. I guess next week we'll continue with the infectious diseases already. So we'll do pneumonia and TB next week. Okay, we were at drug therapy, which we did in detail. Now exercise, of course, this exercise is during good days, okay? So there's no exercising involved when the patient is admitted for an exacerbation. They can hardly breathe, so much more exercise. So exercise is done when the acute episode is over. This is more for rehab or when they're discharged home, okay, just to build up the resistance. Suctioning is always as needed. Let me emphasize that again. So throughout this textbook, in chapter 38, where suctioning procedure is discussed, this will be repeated constantly. Suctioning should always be done as needed. However, the assessment for the need for suctioning is routine, meaning you assess the need for suctioning every 2 hours, but you only perform suctioning how often?
As needed.
Only as needed. So meaning no routine suctioning, okay? Again, that will be discussed in chapter 28. We are out of time, so I will just discuss that.
Wait, where are we?
I'm on tab 579.
Thank you.
So hydration, this is, unless of course contraindicated. Remember, some of these patients do have cor pulmonale. So if they're having heart failure at the same time, heart failure symptoms at the same time, increasing fluid might not be indicated. But in the absence of that, no contraindications, then hydration will help liquefy secretions. We have devices such as this one. This one is a Flutter brand, but there are various vibratory positive expiratory pressure devices. So there's one called Acapella, or this one is the Flutter valve. They have the same mechanism, they just have different designs. So the idea here is to cause vibration. If they blow into this device, it will cause a metal ball here to vibrate, and that vibration is moved to the chest. Of course, they have this mouthpiece in your mouth, so as the metal ball vibrates in here, that vibration is spread into your chest, so that will help loosen the secretion. Surgery, we won't cover surgery because I never heard of many patients curing COPD from lung after using surgery. Okay, so pretty much your lungs are shot, you need new lungs. Okay, we don't have that many. So for plus the concept of transplant, whether it's a solid organ or cells or tissues, will be discussed in your 5th semester. We already managed chapter 17. We did transplant rejection management, and that's all we are testing at this point. All right, so I'll end here. Any questions?
No.
Professor,
Yes.
the flutter is something that's placed in?
No, these are just given to the patient. You know, like your incentives barometer.
Right.
Yeah, so these are also given to the patient. They
Okay.
take right. These are disposable.
Okay, thank you.
All right, so I'll see you again next week. Well, if we get next week is the exam, so
So do we log into this app again for the exam?
no. Details about the exam because they're still debating on which one to use. There are 3 products being chosen by the company, so once they decide on which one, then I'll give you details on how to use it.
You guys are giving me more anxiety on top of the corona and the news and stuff, just so you know.
You're welcome.
Professor, one more question. I noticed that your layout for the logins, it ran all the way till April 28th, but the last day and the final was scheduled for like April 21st. So what are you doing?
Don't worry about it.
What? I have to worry about it. You giving me an extra week of work.
Anything else?
But wait, we didn't miss a class. So that's a legit question. We didn't miss a class. Why do we have an extra week?
Any other question?
Good night.
Right.
Get home safe. I'm going to ask you it every week until the 28th.
Alicia,
Bye.
hang up. Bye.